A very good afternoon, everybody. I am Dr. Komal Chavan, Chairperson Foxy Medical Disorders in Pregnancy Committee, welcomes you all for this webinar on pregnancy with or without COVID, do's and don't. We all know that the whole world is under attack and everything is under lockdown. This was a video which was shown about the lockdown of the Mumbai city by day and by night. This is all because of the COVID-19 pandemic terror, which is stretching out. Billions are under threat. Thousands has already lost the battle. The whole world is locked into fight against this invisible enemy. Amidst this panic, we doctors are on the work front to save comfort to all the patients who are coming with COVID positive and suspects. The first COVID positive delivery was done by team of doctors at AIMS. There are many other news reported about pregnancy in COVID, and many hospitals are having this suspected patient landing up in their hospital doors or their RR and delivering. With this increasing number of patients, we gynecologists are under dilemma in managing such patients and also the need to know how to keep ourselves, our staff, and the hospital safe. So today's panel will focus on these important practice points with galaxy of eminent panelists from all zones of India. A warm welcome to all of them. So without any further delay, I, from Foxy Chairperson, along with the team Science Integra and our partners MCure, would like to welcome the moderator for today's panel, Dr. Nilanjan Chavan. He is a Professor Unit Chief at LTMGH Sion Hospital, having 30 years of teaching experience in the most busiest medical college in the city of Mumbai. He is Secretary of Mumbai Obstetrics and Gynec Society, Secretary General of Maharashtra Chapter of IAG, and he is on editorial board of European Journal of Gynec Oncology. Over to you, Dr. Nilanjan Chavan.
Thank you, Dr. Komal Chavan. It's a pleasure to have the galaxies today, and we welcome our speakers. I request the team to put the CVs of our expert panelists. We have amongst us the galaxies of stalwarts which have been part of TOG, which I recollect was started in 2017 by Dr. Reshma Pai. And we have none other than the first panelist with us, our own Padma Shri, Dr. Alka Kriplani. As you are aware, she is the president. Yes, madam, welcome. She is the president of Foxy 2016, president of Jesse, president of Gynae Delhi Endoscopic Society, and also was the president of AOGD. She was on the editorial board of Asian Journal of Obstetrics and Gynecology, and also was a vice president. She was a former head of AIMS, and a very lively and a wonderful person. Welcome, madam. Thank you.
Thank you. Thank you.
I call upon none other than our past president, Dr. Hema Diwakar, madam. We all know, but an introduction is very must. She was the president of Foxy in 2013 when I got the opportunity to work with her as a chairperson of the oncology committee. Presently, she is the Foxy ambassador to FIGO, and she has a lot of work on GDM and is a vice chair of the FIGO GDM working group. We all know about the artistry and the educational functions which it provides. She is the CEO and the chairman, and also does the Asian Research and Training Institute for Skill Transfer. That's what it's named. She's also the technical expert on the government of India and has received many awards, one of that being the FIGO International Women Achievers Award of 2015. She was also the ex-senior vice president of Foxy and actively working presently with research projects in rural India. And how can we forget her contribution in Manyata along with Dr. Rishikesh Pai. Madam, welcome to this TOG webinar number 3.
Thank you very much, Nilanjan. Namaskar.
Now I call upon our next panelist, Dr. Reshma Pai. We all know she is an epitome of beauty, grace, and elegance, with all the three Devis with her. Presently, She is going to be now the president of Mumbai Obstetrics and Gynecological Society, and I'm sure that the lockdown will be released very soon, and you will take over the reins from us. She was also the president of Foxy in 2017, SR president in 2018-19, and our IAG president in 2018-19. Presently, she is assistant treasurer of the International Federation of Fertility Societies. She has her own consulting. In addition to that, she consults at Leelavati, Jaslok, Hinduja Healthcare Hospitals. She has been last year confirmed with a fellowship and UNDEM of the Royal College of Obstetricians and Gynecologists, London. We welcome you, madam, on this forum. Now I call upon my friend who was with me in my residency days and who is a big name now in Foxy, Dr. Bhaskar Pal. He is representing East India Zone and also was the vice president of Foxy from there. Presently, he is the head of managing COVID patients in Apollo Hospital and also a senior consultant. He is also the secretary of Indian Association of Gynecological Endoscopists and also is the chair of RCOG Indian East International Representation. And he is also the president-elect of Bengal Obstetric and Gynec Society and ex-honorary biostatistician of the Journal of OBGYN. Thank you, Oscar, for joining us in spite of your busy schedule.
Thank you, and welcome everyone.
Thank you. I call upon the young joint treasurer of Foxy, Dr. Parikshit Tank. He is associated with Ashwini Maternity Surgical Hospital and also goes to the Jupiter Hospital in Thane and is an honorary professor of Pacific Medical College of Udaipur. He was the chairperson of the Safe Motherhood Committee Foxy 2014 and 17 and presently is the managing committee member of MOGS. He has got numerous awards and publications. To name a few, he has stood first as a gold medalist in DNB, that is Dr. K. Bhaskar Rao Gold Medal Award. He was also the orator of Kamini Rao Orator and has more than 100 peer-reviewed publications. Welcome, Dr. Parikshit Tank.
Hi, thank you. Thanks everyone for logging in.
Thank you, all of you. And we have a surprise special guest which we will introduce in the later half of our program. And I would start presenting with the COVID scenario. We are all aware what is happening in Maharashtra. Today we have got more than 1,018 cases. We have got 600 cases itself in Mumbai, out of which it is a really bad scenario, and 64 people are no more with us and 30 of them represent Mumbai. Similarly, the situation all over the world is also bad, and we would be discussing the case scenarios one by one. So I would request now Dr. Alka Kriplani to take this question of mine. It is basically a patient who has come to us with 9.3 weeks period of gestation, and she is a 26-year-old lady. She has history of fever and cough, and she has an ultrasound showing missed abortion. So, madam, I would like to ask you, how would you go about in this case? Would you like to go ahead with a medical management or use a manual vacuum aspiration? Your take on this?
Yeah. Hi, Niranjan. Very good initiative. See, this patient is a case of suspected COVID and she has a semi-emergency situation. The best option is, once she is having fever from obstetrical point of view, wait on for a few days till her fever subsides. Because if she is going to go into full-blown COVID, then we may be in trouble. And once her fever subsides, then in this situation, medical abortion may be a better option because we don't want to call her unnecessary. And there are some do's and don'ts when we advise them medical abortion, like how to procure tablets. They need not be called again and again because she's a suspected COVID. And secondly, it is the duty, because she has reported to an obstetrician, to be reasonably sure whether she is COVID or not. So we have to do contact tracing. We have to ask her whom all she met, whether there was history of foreign travel. after assessing reasonably that she is. And then if her fever does not subside, we have to advise her testing. And when we are going to do for medical abortion after reasonable watchful expectancy. In medical abortions, there are very few and very important do's and don'ts, like you need not call her again. You need not do all this HIV and routine testing, which we call in routine cases. Of course, if she has some other symptoms, or you think because they are prone to DIC and bleeding, and you need not call her for NTD also. So these are the RCOG recommendations, very rightly so, because we want to avoid contact as much as possible. And verbal consent is to be taken. How she comes, she should not come in the hospital, this thing, ambulance. And once she comes, if she is having fever is bad, so she has to inform, so that she has to has mask and all those precautions for COVID. If it is suspected, she is a suspected COVID because of fever. From obstetrical point of view, two things: wait till her fever subsides, because then course of this thing will be again known. And secondly, medical abortion will be a better. If it fails, then of course we have to go for surgical, as we know. Thank you.
Yes, madam, you have wonderfully explained. This is an experience which I also had in my hospital, and we waited for her fever to subside, and everything was fine with her. After 4 days, we evaluated her whether she was COVID positive. The swabs were taken, and then later on, we went ahead and did her MTP. We can also go ahead and do a medical abortion in such case, but all these precautions have to be taken into consideration before we go ahead. So thank you very much, Dr. Alka Kriplani, madam. It was a wonderful sharing thoughts of managing a case who comes with us.
Welcome, Niranjan.
Yes, madam. You will be
I must congratulate you for this lovely initiative.
Yes.
On an
Madam,
appropriate time,
yes.
Appropriate topic.
Yes, madam. There is one more question. It's similar to that only. She is 6 weeks pregnant and she seeks termination. The patient has got a high fever and cough now. I mean, obviously, we had the previous case also who had the same thing, but she is in an incubation period of 9 days in home isolation. This is also a scenario, madam. So
Very good
should
question.
you admit such cases? Madam, you should admit this case in a COVID hospital isolation ward, or would you recommend her to go ahead with a medical line of treatment at home?
Very good question. So there are two issues in management of this patient. One is from COVID point of view, and second is from obstetrician's point of view. Now, if she is having fever, and we have to see whether it is associated with high fever, dry cough, diarrhea. So we want to be reasonably sure. And this is the patient who requires testing also. But if her symptoms are not very bad, we have to wait on before sending her to COVID. If she deteriorates, definitely she requires admission in COVID facility. From obstetrical point of view, 6 weeks pregnancy, 9 days incubation, we have to wait on. Watchful expectancy. Let her fever subside. Let her come out of that crisis if she has to. And once 14 days are over, in all probability, she will be much less infective. Then we can go ahead with medical abortion. Now, the next question is medical abortion. What are the do's and don'ts? It's very appropriate to discuss here that medical abortion, giving her MIFI and meso, is a very good idea. Again, don't call such a patient. Try to minimize the visits. The RCOG also says ultrasound is not a must unless she is high risk for ectopic or there is some other associated problem. And NTD, again, you need not call. For pain relief, we have learned Brufen should be given, and all these prescriptions can be given to her. And if facilities are available, she can be sent the prescription. But at this time, watchful expectancy till 14 days are over. See the course of disease, what is going on. If she improves, she becomes all right, becomes non-infective, go ahead with medical abortion. If she deteriorates, she requires admission in COVID facility.
Absolutely, madam. I think you have given justice to this question, and now let's move on to the next question.
Thank you.
And I call upon Dr. Hema Divakar, madam, to please take the next question. Dr. Hema, can you hear me?
Niranjan.
Yeah, madam, we have a third gravida para 2 patient of 33 years old. She is 39 weeks of pregnancy and there is no history of exposure of COVID. Okay. However, she presents with cough for 2 days with increased fetal movements and patient does not have any fever. There is only cough. But then we tested her and she turned out to be COVID-19. So now we have this patient at 39 weeks of pregnancy with COVID being positive. So do we admit her? Number one. And how we would go about to monitor her for the development of labor. And if there are increased fetal movements, is it a sign of fetal distress? And would you recommend for cesarean section in this case? I have divided this into 4 parts. It's all yours, madam. You can go the way.
Dr. Niranjan,
That not.
was previous deliveries, vaginal deliveries or C-sections or?
Madam, she has a uterine scarring which was there in, so she is a previous LSES, but she has presented with cough now, with tested positive of COVID, and she is not in labor, madam.
Okay. Here again, 2 issues. You said she's gravida 3 and this is her 3rd pregnancy. So maybe she has 2 previous scars, which means the intervention as an obstetrician, if we have to decide, then it's an obstetrical indication for a C-section. Even without the COVID, normally if she would have presented with 2 previous scars, most of us as OBGYNs would have posted her electively at 38 or 39 weeks for a repeat section because being no other comorbidities which you haven't mentioned, whether she is hypertensive or gestational diabetes, we are presuming that all that is not there. In its
Yes,
own
madam,
merit,
it is not there. Otherwise,
so,
our discussion will go for 15 minutes more,
so
madam, and that's why.
what I mean to say is those are important factors to be noted by an OBGYN.
Absolutely, absolutely, madam. Yes.
Scale up her risks. Okay. So having said that, she is a 3rd time pregnant, 2 previous scars, 39 weeks, no fever, but cough, and rightly so, she has been triaged and tested for COVID-19 and she is proven to be positive. Now, COVID-19 positive patients can either have mild symptoms as how in this patient is presenting, or she can be moderately sick with little respiratory distress and all, or she can be really, really severely sick. If she is really severely sick, yes, Bhaskar is in charge of the COVID hospital, designated hospitals. We would, without a category. Even then, since we as OBGYNs have very little experience in dealing with the complications of the COVID positive cases, it is better that she is handled in a designated COVID hospital. She may not at the moment need a tertiary care, but she may deteriorate non-obstetric major organ failures, etc., which need intensive care and a multi-speciality team to take care of her. So in our wisdom, I think if we haven't discussed the transfer with her, we should do and give the choice to her. Of course, I agree that in low resource setting, not in every little town a COVID designated hospital may be available. Then she falls on our lap. And I think if we are intervening with a C-section, then the PPE and every prophylaxis that needs to be taken in the operation theatre needs to be taken. And also in her ward, the housekeeper should be instructed to do the disinfection with 1% hypochlorite solution every 3 hourly, and the mopping also has to be done accordingly. Everybody in the hospital needs to be sensitized and sensitive to how to handle this. May it be the social distancing, repeated hand washing, the repeated housekeeping instructions, etc., which comes along as a package with the process of repeat C-section as a process of delivery.
Yes. Hello.
Don't have a choice to transfer her to a COVID-friendly hospital. You have to deal with her in the manner that I have said. keeping in mind that she has only cough, but fever may develop, fatigue and myalgia may develop, the deterioration of the pulmonary functions can happen, her respiratory rate needs to be monitored, her mental state which is altered or not, and her systolic BP if it's dropping less than 100, and if at all, if she's also having oxygen saturation less than 93. So all of these
all these parameters will have to be
and deterioration, and you have to be on the alert and watchful for all of these, because today you may think she is a mild case, but you may land up into problems if you are not alert on a deteriorating situation.
Yes, madam. Unfortunately, she was not in labor, but then later on she developed fever, and we had to do a chest CT, and it showed a unilateral pneumonia. Patient was given oxygen therapy, as you already said before. Now, madam, should we take her up for section, or we should wait, or should we start her on antiviral or HCQ or azithromycin, etc.? What would be the drug of choice in such case? And would we wait and treat her first, or go ahead to go for a section later on or now?
If you wait on, she may develop obstetric complications as well, and we may put the fetus also into trouble. And she's previous to scars. Okay, so the fever is also developed. So there's every chance that she will get into labor, because this may precipitate the onset of labor within itself. So first thing is to involve a multi-speciality team to stabilize her. You already have the evidence by the X-ray also about the pneumonia, so she is not going to be simple to deal with. The general things which we as OBGYNs can do, yes, the fluid therapy, hydration, rest, nutrition, she is now bypassed all those. Now you're left with the choice of the step-up medical therapy, which comes under two categories. One is the HCQ and azithromycin, which may be added because if there is a bacterial infection as well, and there is a okay, the other category of drugs which we can use is antiviral. As on today, versus the care, in addition, you give her the antiviral drugs such as Lipanavir and Ritonavir in the 400-100 combination. We are not the best of the experts for that. So you need to seek help with the one who is seasoned in this subject. And as a no option kind of a situation, you don't know whether it will help or not. You may give it in good faith, the HCQ, the azithromycin, and the antivirals. These are the three categories. It may be very, very difficult for us to make a choice without a expert team coming together to tell us what exactly to do.
Madam, you are spreading magic. The way you have answered, the charisma which you have, and the enthralled by your answer, and you have absolutely said that we have to see accordingly, give our antibiotics. We have got more than 1,500 members online presently hearing, and I think you have given a wonderful justice to this question. I move on to our next panelist, Dr. Reshma Pai, madam. Welcome.
Hi.
Yes. This is a 29-year-old pregnant woman, and she is at 36th week. She has presented with bleeding, and the ultrasound shows placenta previa. Luckily, she is not having fever and cough. But in the COVID lockdown time, in such a situation, she could be a suspected case of COVID. We have to take that precaution. So now she is 36 weeks. Do we give her steroids in such situation?
Yeah. Okay. So the first thing would be in today's would be to take the history of possible exposure to find out if she's had any foreign travel herself or contact with somebody who's infected So that's the first thing. Second thing, that obviously if you come into the hospital, it's a different story, but otherwise at 36, should be registered with us, and we have to inform all our patients that they should call in before they come in so that we make preparations for them to be received when they come in. There is a suggestion, and it's not yet mandatory, that almost all our patients who come in at this present acute phase of COVID-19, they should all be tested with the RT-PCR test. And many of the hospitals who are treating patients today have made it mandatory for a routine PCR test for the patients. It comes in a day, the report, in the morning, the report is there with us in the evening. So we can send a report, you may not have it with us immediately. Once the patient comes in, today we have to treat almost all patients as if they may be potentially infected because they could have been exposed 2 weeks prior or 10 days prior and may be completely asymptomatic. So patient is received today with universal precautions. Patient is taken into the room, which is like a labor room, plus her going to be isolated in that sense, or at least separated in a good distance from her neighboring patients. The receiving doctors and the personnel have to be minimum. They have to be in PPE suits today. So all healthcare workers should be in PPE. Patient, the doctor who's actually receiving any patients who may or may not be a suspected COVID, we have to consider that they are on prophylaxis hydroxychloroquine. Once the patient comes in, routine consent is taken, plus an additional consent because she's placenta previa with bleeding, so high-risk consent, and a separate COVID consent also nowadays requires to be taken, that there may be an exposure while in the hospital. If she develops COVID, that there may be, a term event may happen. So separate specific consent has to be taken. Immediately blood has to be collected, obviously for cross-match, but also for basic run of tests we can do, including a CBC, because you know that sometimes if there is a infection looming, there'll be low counts, a CRP may be elevated, liver enzymes may be elevated. So basic test immediately which we do, which we get quickly the results, will give us this information if there is a patient who might be in the latent phase and getting the infection. Obviously, further management will depend upon her degree of bleeding, whether she's stable, not stable. Minor bleeding, complete bed rest, monitoring, she may settle down. Obviously, if she has torrential bleeding, the question of waiting doesn't arise. So the moment you stabilize her, start her on IVs, keep blood ready, have the system in place, you will have to deliver her by cesarean section. The question of steroids, patient is not infected. She has a good respiratory rate, no obvious desaturation, no obvious evidence or symptoms of COVID. There are many studies today saying that between 34 to 36 weeks, which is the late preterm births, they benefit significantly by the administration of antenatal steroids. In fact, there's a very good study in New England Journal which says that between even up to 36.5 weeks, if steroid is administered, the neonate has much less transient tachypnea of the newborn, much less use of surfactant, less respiratory distress. So if there is no crisis in terms of bleeding, then we should give this patient steroid. We should observe her for a period of time. And if we can wait for that 24 to 48 hours, we should deliver her after that if the bleeding continues. So I think we have to treat her like a normal obstetric patient. Yet in today's times, no patient is COVID-free unless proved otherwise. The doctor has to be on prophylaxis. The patient has to be treated like a potential. She has to be given a mask. She has to be kept at a distance. Number of relatives have to be reduced. The entire hospital has to be vigilant to the possibility of the fact that this patient may be a potential carrier. Niranjan, anything else you want to know? So I think I had certain information that I felt we should be sharing, all of us, in today's times when any of us may face a situation when we are dealing with potential COVID patients. Obviously, if a patient is proven to be positive, she has to be referred to a COVID hospital. But if we are not sure of her status, or if her family member has COVID or she's been exposed to it, then we may have to deal with that particular patient. And I feel all our nursing homes may need to be prepared now for COVID-19 patients. And since it is not possible to have every single nursing home prepared, if it is possible in the near future for us to form a partnership or a group practice, then we can identify a good nurse in our practice. Some of the doctors get together so that we can even split up duties. The personnel, very few nurses and IAs are reporting on duty. So we can all work. And this is the time that we should work in a group practice. Maybe, we can do duty for a few days, followed by, and we can pool our teams, and we can give the best possible care to our patients. Because everything is in, including personnel. I think we've lost connection from Niranjan.
Thank you, Dr. Reshma. Yeah, it was so few to present it. Now we go to the next panelist who is there with us. I request Dr. Bhaskar to come online.
Hi.
Bhaskar?
Yeah. Can you hear me?
Okay. Now, yeah, I can hear you. We have got the similar patient of 40 weeks now. And basically, she is to be taken for a section now. So what are the things which will you be doing for this patient, and how would you explain about the donning and doffing for a gynecologist, the anesthesia team? What would be the mode of anesthesia you would like to go ahead with?
All right. Okay, a small clarification. We are not a COVID hospital. We are a private hospital who are allowed to treat COVID patients. So we have a COVID ward, we have an isolation ward, and we have a COVID ICU. So we can take care of any COVID patients that is possible. The second issue is obviously there's a COVID team in place where I'm a part of. Nobody hates anything. We have excellent leadership here. That's not the issue. But the point is such, I do not know what the situation is Mumbai is, but at the present moment, at least in our hospital, the situation is such that we have to assume that every patient is COVID positive. I would give one, so if this patient needs a section today, I would rather take universal precautions rather than testing her. Because there are two reasons. Number one, the RT-PCR testing has a false negative rate of 10 to 40%. And the false negative tends to be around 30 to 40% if the patient is asymptomatic. So you might get a false sense of security if she tests negative. If the patient has got any symptoms, I would test her. So at the present moment, when you talk of PPE, we need to understand that there are three levels of protection. One is a contact protection, one is a droplet protection, and one is an aerosol protection. So you need an aerosol protection only if you are doing a procedure under general anesthesia. And whereas you need a droplet protection, which if you are doing a procedure under spinal or regional anesthesia. So you expose yourself and your team much less if you are doing the cesarean under a spinal or epidural anesthesia. Although people do not know whether the temperature of a diathermy kills the virus or not, people are advocating to err on the safer side and consider diathermy as an aerosol generating procedure, which means we go back to the days when we trained, we didn't have a diathermy and used to ligate those bleeders in a cesarean section. So which means if you do a cesarean section under spinal anesthesia and avoid the use of diathermy, then what you need essentially is your N95 mask or a surgical mask. And you essentially need a gown which will cover you, and it will something like the gown that you wear in an HIV patient. You do not need an FFP3 respirator, which is anywhere not available in India. But if this patient needs a general anesthesia, then several things that you need to follow is that all the anesthetists and all the surgeon and all the surgical team and other personnel in the theater need to have an N95 mask plus a visor mask on top of that, surgical goggles, and you need to have a double gloving. Now, while donning is relatively easy because when you are donning it, you are not actually infected. But when you are doffing it, it is very, very important that is the time when you can spread the infection. So the FOXY guideline very nicely illustrates the picture that how you should doff. You take off your first glove and then you take your gown and glove together. Then you wash your hands. Then you start removing one by one. and everything has to be disposed of correctly. But I think the easier option for us to do is to do a cesarean section under a regional anesthesia and avoid the use of diathermy and take precautions, what we call is a level 2 PPE precautions or a droplet precaution. That is what we would advocate.
Excellent, Bhaskar. You have done justice to this question and wonderfully explained the details about it. Now, I would like to invite our special guest and speaker, and it is none other than our own Foxy President-elect Dr. Shanta Kumari, who has come from south of India, and we have 1650 viewers presently with 265 questions being asked. Welcome, Dr. Shanta Kumari. It's a surprise for us that you are present amongst us. This is the third TOG webinar, and I am really happy to invite you. Dr. Shanta Kumari, are you online?
Yes, Niranjan. Hi.
Yes.
Hi, everyone.
Yes, madam. Yes, madam. I know you do not require an introduction, but I have to do that. You are the president-elect of Foxy 2021 and a senior consultant and laparoscopic surgeon at Somaj Guda, Hyderabad. You have donned many hats in Foxy and in FIGO, and presently you are a member of FIGO working group for violence against women, and we have seen those marches being done at Hyderabad HICC along with FIGO president and your chair, and you have also been actively involved in IAG and in other organizations. You were also the Foxy committee chair in 2008 and 10, and you have received awards, namely to be said about FRCOG in 2018, FRCPI of Royal College of Physicians of Ireland, ICOG secretary. You have initiated Dhira, the project which is violence against women, and you have been also the vice president of Foxy in 2013 and secretary of TCOGS 2017-2019. You have received also CL Javeri Award at 42nd AICOG 1998. And obviously, we have seen the charisma of Shanta Kumari day in and day off. And since last more than 12 years, you have been organizing those conferences, namely Foxy FIGO 2013, ICPHRP 2015, and ICOG in 2016, and again a FIGO conference in 2017, and so on and so forth. The last one, which was the Foxy Tigo 2019 conference, we witnessed tremendous faith and confidence from you, and the delegates had enjoyed your conference. Welcome, madam. It is wonderful to have you. How are you? How is Hyderabad?
Hyderabad is perfectly okay. I feel so much better seeing all of you, you know. I think
Yes,
we are all having the withdrawal syndrome where we are missing each other. I think this webinar is one which is connecting all of us together. So it's a wonderful initiative, and actually I also learnt a lot listening to today's webinar. So we had Dr. Alka, Rishma, Hema.
Okay. So we have, yes. We have already the Rishma, the Dr. Bhaskar Pal, Dr. Hema Divakar, Dr. Parikshit Tank, our joint treasurer, and obviously Alka Kriplani madam is also there with us. We have already begun, and we would like to share and expect you to have your take on Hyderabad. How is it going in COVID situation?
In fact, you know, though I'm coming from the smallest, newest state, Telangana state, our government has done a very great job. In fact, you know, they were very proactive and tried to contain the COVID in all possible manner. And in fact, when you just look at the incident which has triggered a spurt of cases, it was the Telangana police and the Telangana government which actually found out the link and made the center and everyone aware. And that is also, I think, is now going to help contain this issue all over the country. And I'm hoping that very soon this sort of containment of this COVID will happen, and lockdown is something which is actually the absolute need of the hour. So that is the social distancing and all the things, now everyone knows everything thanks to the social media and the news and 24/7, I think, the television and everything. And honestly speaking, I think I can see Bhaskar is also.
Madam, would you like to pose a question to Dr. Bhaskar?
Yeah.
Madam, would you like to pose a question to
Yes.
Dr. Bhaskar in continuation of our question about management on COVID?
Yes, Bhaskar, I was quite surprised to see, and I mean, we are very happy also. The number of cases in Bengal are very less, so I think you all are very lucky. And you had mentioned that your hospital is a private. I know Apollo is a private hospital. Like, as of now, has your government agreed to utilize the private sector hospitals for the COVID patients, or they're sticking to the public hospitals?
No, the government has agreed to get patients treated in private hospitals. Without getting into any further details, please don't ask me any further details, but the situation is not what you see. We are under-testing tremendously, and we are not very transparent with our figures. But at the present moment, I can assure you we have a lot of patients. We have overfilled wards. So we have a designated capacity for taking in COVID patients. Beyond that, we send them to government hospitals. Many private hospitals have admitted patients and then later who have tested positive, and those patients have not been moved out of there. The government has designated one hospital in Calcutta as a COVID hospital. But at the present moment, so any patient who's being generated out of the government sector, which is a very good idea because patients with fever would go there. So we are actually firefighting on a daily basis. Like every day we see the situation's got a little worse, and then we change our strategy. Like yesterday morning, our strategy changed to any patient with fever or cough will not get admitted in the main hospital. They'll get admitted in a separate block in isolation, irrespective of whether our degree of suspicion was low or high. As of this morning, our situation has changed and we're taking everybody as COVID positive unless proven otherwise.
Yeah, I want to share my thought on the testing part. So we have to understand that especially our government, we are right now, the testing is done only in the public sector hospitals, and private sector has not been given an okay as on now. And all the private hospitals, up to a maximum of 3 patients, they can send for the testing. And right now, we are not actually having the universal testing, and it's not advocated at this junction. So I rightly agree with Hema, as she's put in, the universal testing is not done. So I think taking universal precautions is the best in the present scenario.
Absolutely.
In future, probably maybe a time will come when it may become a routine test. But as of now, what I would tell all the doctors, because now everyone is a COVID specialist, be it an ophthalmologist, be it a gynecologist or a dermatologist. Please what I would request all the gynecologists is don't go onto the social media and talk about we need to do more tests, we need to do universal testing. That is creating panic, and that is going to actually affect the scenario in how we are going to handle this. We need to agree on this particular point.
Yeah, universal testing will become useful when it becomes like HIV, when we have a test we can rely on and we have a very quick turnaround time, that we can get a report in a few hours and the report is reliable.
I think the main other question is, many of the doctors in the small nursing homes are very worried. How do we go back to our work immediately after the lockdown is lifted? But as of now, we have seen that I think in all probability the lockdown is going to be extended probably up till the end of this month.
Or maybe relaxed, or maybe it's a phased out, whatever it happens.
Right now, I think Maharashtra or Telangana, it looks like probably it is going to be extended. Probably when you actually have a phased out lockdown, you come out of your lockdown, I think the universal precautions of all your masks, then hand sanitization, all should be continued on this aspect.
I'd like
would like to add something.
Yeah, I'd just like to make that, for example, by the number of the maximum country, and they are using numbers. Fortunately, we also mortality today. Full-term patient died with COVID and unfortunately lost her baby as well. And so I think things are getting a lot worse in areas. And when we are looking particularly, and I think there is much thing going on. So many of our clinics are now testing. Slightly homes are making it mandatory to have a COVID test done for patients who are coming in electively to the hospital for their full term or they're coming in for delivery. So, I think that is protecting the healthcare staff. Please remember that in Mumbai, Saifi Hospital shut down because a large number of patients were found positive. Jaslok Hospital, supporting hospital for Mumbai, shut down for the last many days. A large number of nurses was found positive. When they got exposed, nobody knows. Some of the patients are asymptomatic. So rather than getting shut down, today there is news of Breach Candy Hospital. One of the nurses has tested positive. So rather than hospital getting shut down, entire wings getting shut down, huge staff getting quarantined, I think it is better to test that one patient who comes in. The number of patients is lesser. The number of hospital staff is huge. Not only doctors, but nurses, ward boys, restaurant staff, food supplies. The chain is huge. We have them. So I feel testing has to be done in places such as with large number of cases, particularly Mumbai.
Thank you, madam. Thank you so much for your expert comments. Now, Dr. Parikshit, are you there? We can see you. Hi. If we have to do a tubal ligation on this case, would you recommend it in a COVID positive patient? And the next would be, following cesarean section, what are the guidelines for breastfeeding?
Right. So two separate questions, of course. One is about the tubal ligation, and that's hardly an emergency. So I would strongly recommend that this couple use some other form of contraception for a while, and then we can come back to the permanent forms of contraception at some later point. Breastfeeding is a little trickier problem because here we are looking at two scenarios which might evolve in the next few weeks. One scenario is where, as we are at the moment, we are supposedly in stage 2, where there are only clusters of infection. And we do have facilities, we do have the bandwidth to cater to these delivered mothers on a one-to-one basis. So here we can at the moment follow what was recommended in Wuhan, and that was to isolate the neonate from the mother, have the neonate cared for by some other family member. Breast milk can be expressed by the mother taking respiratory and hand hygiene precautions, and then that breast milk can be given to the neonate. However, if we start seeing numbers going up and a large number of deliveries with a community spread kind of a situation, then the logistics of keeping the neonate away from the mother might be too much to handle. In that sort of a situation, we'll have to go into rooming in kind of a solution, and then the mother using all the possible hand hygiene, respiratory hygiene precautions, which should protect the neonate from the infection. I would like to make one important point here, that breast milk does not contain the viral particle. The viral particle will go to the neonate via respiratory droplet, just like the rest of the population. It's not a vertical transmission like what we've seen with viral diseases like HIV. It's not that kind of a situation. So the important thing is not the breast milk. It's the act of breastfeeding which needs to be isolated from the breast milk.
Okay, thank you. You have said properly that emergency section, if done, doing a tubal ligation is not important. You can do it later, and breastfeeding doesn't cause any harm to the baby. You can surely go ahead and give it. I call upon Dr. Hema now. Thank you, Dr. Parikshit. Dr. Hema, you wanted to say something about testing, and now the forum is open for questions. The questions have piled up now to 300, and we have got more than 1800 viewers right now with all of you. Alka Kriplani, madam, the way you have started this presentation. After Hema, then we will ask Dr. Alka Kriplani to have a special comments. We are lining up the questions. There are questions for Rishma, for Bhaskar, for Parikshit, for Shanta Kumari, and everyone.
Yeah, Dr. Niranjan and the esteemed panelists. See, the moment the rapid testing is going to be introduced, that is from today, there is an extra bit of confusion about the types of testing and what is the significance of these types of testing. Even on the media channels, you will find a whole lot of confusion, and people are under the impression if rapid testing can give us the reports in 20 minutes or half an hour, why are you not doing the rapid testing? So we as clinicians should very, very correctly understand to tell the patient what test is for what. As of now, all the pregnant women without any symptoms walking into the consultations cannot and should not be subjected to a PCR testing. That's for sure. There has to be a triaging area where the travel history, the contact history, the tracing, the cough, the fatigue, the myalgia, the fever, etc. has to be taken into consideration. And then we have to send her to the designated government setting for the RT-PCR. That is one thing. Once if the rapid tests come in and the private practitioners are also allowed to do this test, because you can infer something in the 20 minutes to half an hour that the patient before she is let out with the question mark. So there again, if it's negative, it means it needs to be retested. If it's IgM positive, it means it's recent infection. If it's IgG positive, that means this patient has bypassed her infective stage and moved ahead, so she's not a threat to anybody. So this kind of an understanding is a must, and we will come to terms with that very soon as how more information becomes available to us, so that even the FOXI guidelines can accordingly be modified. So that's how I always say the information is dropping in by the minute, and what we say today may not hold good for late tonight or tomorrow. So each one of the viewers, kindly update yourself with everything that's been put out on the FOXI website as well. Dr. Alpesh Karthi and team, we are one of the professional organizations in the world who have responded very, very quickly to give a professional advisory and recommendation to our community of OBGYNs at the earliest, given the fact that, yes, we will need to amend it, modify it as we go along. So the present status about the testing is how I have just placed before you. Yeah, thank you.
Thank you. The nation wants to know. The nation wants to know what Dr. Alka Kriplani wants to say. Dr. Alka.
Patients, the psychological handling and psychological care of the patient. Patients are repeatedly ringing. They are very much in panicky. What will be the effect of corona on my baby? So for the patients as well as our colleagues, when you are counseling your patients, they are in a panicky phase. These are the things. Patient will ask you whether my baby is at higher risk of congenital malformations. Tell her there is absolutely no evidence. Whether there is high risk of abortion, no, it is not there. Whether there is high risk of preterm labor, it depends. When patient is very, very sick, then only there is higher risk because of her condition of respiration and all, otherwise not. Is there risk of IUGR? Studies have not shown. But if we extrapolate data of SCAR and H1N1, then you know that they had higher risk of IUGR. And after that, whether doctor you are going to do cesarean, please do cesarean. This is for when you see the studies all over from Wuhan, China, after 38 they did cesarean in 35. It is basically not for the patient because it is for obstetrical indication. It is for the culture, the person who is delivering, how long they can be in contact with the COVID positive patient, how they can save themselves. I think that is the reason higher incidence of cesareans are there. So all these things we have to tell our patients repeatedly and to reduce. And if they ask what will happen if I get COVID in pregnancy, whether it will be very serious, it is not so. The immunity is not making much difference, except in very late pregnancy, there may be slightly higher chance. So they need not worry. But pregnant patients have been put in a vulnerable group. So they should take extra precautions of religiously following lockdown and not getting involved with any possible.
Dr. Bhaskar, the nation wants to know. Thank you, madam. Dr. Bhaskar, the nation wants to know whether there are any pre-op tests in non-symptomatic patients which are posted for LSCS.
Not really. Only routine tests. And as I would again say that asymptomatic patients, there are two issues. Asymptomatic patients, by testing, you might get a negative test might give you a false sense of security. That patient might become symptomatic later when she will become positive. So I think that at the present moment, the only positive to go ahead is that treat, especially if you are in a place like Mumbai or Kolkata, treat every patient as potentially positive and then do like we used to do in initial days of HIV. I will also saw a couple of questions coming on the chat, and I wanted to say, I think somebody wanted to ask whether it goes to the placenta. The Chinese data says that there is no transplacental infection. However, I would say that looking at the world data in the last 2 to 3 weeks, none of the data are actually aligned with the Chinese data. So at the present moment, I will take a data coming out of Europe or US much more seriously than I would take from China. Whatever data is coming from Europe or US is the incidence. If a patient gets COVID, her chances of getting a mild infection or severe infection is just like in the background population, which means 85% will be asymptomatic or get a mild infection, 10% will get a serious infection, and 5% will get a critical infection. And these are the figures I think it is important to quote to the woman. I want to ask a question to all the panelists, because at the present moment, I think this is the biggest dilemma. If a patient comes with mild symptoms, which means that she's possibly caught the infection day 4 to day 5, and she's 38 or 39 weeks, would you rather deliver her immediately or you wait for symptoms to go away? The reason I'm asking this is the UK practice seems to be wait for a week, things might get better, whereas the American practice is that the disease tends to be more severe in the second week, and you will not know who is going to be in that 15% category, so deliver them now. And I can see Dr. Alka Kriplani raising her hand. The only pregnancy we had from AIMS, it looks like that they took the American way out and decided to deliver her immediately. Madam.
Bhaskar, you have raised a very, very important point. Personally, I go with the RCOG thing because I tell you, out of 100, as you very rightly said, the data, very few are going to worsen. Then why expose her? Wait on. Majority of time, things will settle down, cool off, and then take delivery. Unless cesarean emergency is indicated when she's very sick. There are reports in the literature they have done because she's having respiratory distress, and you think now the life is more important. That to relieve the distress, they had to take out the baby. So I strongly feel that wait on. One more important point many of us are endoscopic surgeons, and I'm called upon to do ectopic pregnancy or not. So what should be the policy of gynae surgery? This will not be complete unless we discuss emergency and cool gynae surgery. So emergency surgery, especially laparoscopic surgery, should be avoided because usually there is general anesthesia required and there is a serious threat that the aerosols, because of the cautery, as Bhaskar already said, there is higher risk of. I posted a video on the Facebook and every place showing that my own way how to reduce these fumes risk, but it is something which we do not know whether it will work or not. So we have to do what I have started doing. Patients who are coming with very severe bleeding, 5-6 grams, emergency hysterectomy under spinal or epidural with a small phenol incision, telling the patient, so avoiding unnecessary laparoscopies. We are not doing cool and elective surgeries, because if any patient comes out to be positive, whole hospital will be sealed off, and it is maybe later when the cases are more, the policy we might have to change. But presently, avoid laparoscopy. If at all you are required, do your laparotomy, as we all are trained over decades, and no cool elective surgery. Presently, cancer surgery is, yes, cancer surgery should be done in
Madam,
because it is an emergency.
Can I stick my neck out and say a little more?
Yes,
I would say some
little bit,
guidelines have come
little
out about gynae surgery. That gynae surgery, the only oncology that you would operate at the present moment is a stage 1 endometrial cancer. All the others you will try to manage with radiation or chemotherapy at the present moment.
Yes.
For gynae emergencies, ectopic and twisted ovarian cysts, these are our two main ones. You try and do them under a regional anesthesia with a mini laparotomy. If the patient requires a general anesthesia, then you would think of whether to do a laparoscopy, because you're taking anyway aerosol generation precautions.
Then counseling.
Then
Counseling the patient.
Yes, yes.
And we have patients who are coming with severe bleeding, AUVL. 2 hysterectomies we have done in this time. So
I request the panelists, I have to move on. There are 1800 of them online and there are 300 questions, but we are going to ask each one of you how much best we can finish. And it's a galaxy of stars which have come down on earth today, the stalwarts of Foxy amongst us. And it's a magic of TOG, it's a magic of Foxy, where the love and affection of all those members are there for us, and that's what they are stuck online. Even if they are locked down, there are many questions. The next question the nation wants to know.
But Niranjan, one thing you have done a great job. Excellent questions, excellent organization. Later time may not be there.
Thank you.
So from all panelists, I
From
must
all of
congratulate
us,
you.
yes.
Yes, thank you. We will
And
take that.
there
Thank
is
you
no
later.
good, and there is no good panel without difference of opinion. I'm sure we are having ample difference of
absolutely
opinion,
agreeing.
which we
I'm
should,
absolutely
because
agreeing.
this is a disease we know very little about. So we have to go play by our intuition and logic.
So congratulate
next
all the
question I want
panelists
to
for
ask,
behaving so decent.
Madam, I would like
Till
to
now.
take the nation, and the nation wants to know from Dr. Parikshit Tang, the joint treasurer of Foxy, who has made the guidelines of COVID-19 along with Dr. Atul Gadatra and Dr. Alpesh Gandhi, our president of Foxy. The nation wants to know whether there are any Indian studies which are coming now in the next 2 months. You have to plan it, Parikshit.
Yes, we've already started working on the COVID-19 registry for pregnant women, and we have submitted the format to the government. It should be out maybe in a day or two, and we'll start collecting data that will give us, some real-time information about what's happening, what are the outcomes, and we'll get a publication out soon.
Yes, we will be waiting for that. For the time being, we would.
Dr. Chavan,
Yes.
if I may be permitted, we'll be
Yes, please.
circulating this registry format across all the members, and it's my earnest request that if you know of such a case, or if you manage such a case, then please flag me and do send the data to me.
Dr. Parikshit, we would request you to send us the format.
Yes, as soon as it is
we
approved.
Email
As soon as it is
it
approved.
comes.
Yes.
Yes. Now, Dr. Reshma Pai, we did a section and it was a case of placenta previa, but obviously we would like to know, there's one question, whether that liquor is infective or is it going to make any harm?
I answered that.
Already
I
answered.
want to ask. Yes, Dr. Reshma. Madam, your voice, is it unmute? Gaurav, please unmute. I request Gaurav to unmute Dr. Reshma Pai's phone. Can you hear?
It's
unmute. Please go ahead.
Yes,
So
yes, yes.
I think most of the information that we have is from China. They reported 16 cases were positive and 18 patients suspected in one of the studies recently. And all the patients, they did check the placenta by PCR, they checked umbilical cord blood, they checked amniotic fluid, and all the cases showed negative. So there was no transmission in. Yeah, we are exposed to operating these patients very often, calling on us and blood, getting. So in the unfortunate scarcity of PPE sets that we have to be very vigilant. So none of these things have been infected with a virus. However, there are reports coming in of newborns infected. Newborns are not infected, but even this child reported 3 newborns infected. Whether they got infected after or whether they were with the infection, they're right now. I think we need larger numbers for that. But my comments are because we almost reported so far have infection. Most of us are coming, whether positive or suspected or exposed to somebody, as a rule, so patients do not have a normal doctor, But the fact of the matter, if the doctor has to her or him, the PPE suits are supposed to be for 6. So if you're going to induce a patient or wait for a patient in labor who's going to take, sometimes a primary may take 10 to 12 hours to deliver, how are we going to manage the safety for the healthcare workers? The number of staff coming in contact with her, multiple examinations that we have to do, FHS has to be checked. So if this is a 10 to 12 hour process, how is the healthcare personnel going to protect themselves? And that, I think, is the reason why majority of the cases have been delivered by cesarean section, because conditions are much more controlled. You're in hopefully a negative pressure operation theater. Distancing can be put, you can finish your 45, and you can be safely yourself, patient on. So the whole process is safe for healthcare person and allowing to have a long delivery. A patient comes in stage of labor in a short period of time.
Okay. Thank you. There are many questions here. Dr. Geeta, are we legally liable if we refuse to admit patient for delivery on LSAS during lockdown due to shortage of PPE? Dr. Geeta is asking. Dr. Alka Kriplani, would you like to answer that question? Are we legally liable if we refuse to admit a patient? Unmute. Gaurav, please unmute.
On a humanitarian ground, but the problem is we have to educate our patients. They have to go to designated COVID places. Otherwise, because of one patient, whole hospital will be locked down, as happened in Just Look. That will be a bigger issue.
Okay. Dr. Lalita, should we routinely do rapid COVID-19 test like other viral markers for patient for cesarean sections? Dr. Bhaskar Pal.
I think we can answer the question only after we know that what rapid test is exactly available and what it is detecting. At the present moment, it is difficult to answer. If you have a rapid test which will tell you that whether it is IgM positive or IgG positive, then it helps you. If it's an IgG positive, the patient is outside the window. Article accepted in Nature shows very well that from 9th day onwards, nobody was shedding enough viruses to infect others. So your infectivity is during the time when you picked up the infection and not symptomatic till 9 days after you picked up the symptoms. But how the antibody test, only after we know which antibody test, there will be different rapid test, only after we have what rapid test is there. If you look at the ICMR guideline on the interpretation of the current rapid test they have approved, it is extremely complicated. And to me, it actually doesn't lead you much.
And secondly, it will put so much of strain on the system, because presently testing availability is very, very restricted.
In short, it's very important. Yesterday we had Dr. Deep Datta also from UK. He shared his experience with Dr. Rishikesh Pai, and there is a basically it hardly causes ARDS. There is a release of iron particle, and we have less injury nowadays occurring to the alveoli, and giving oxygen RBCs is more vital rather than giving ventilatory support. So we do not have to run for ventilators. That is what the Indian people or the Indian government should understand. It is basically a release of ion binding which goes haywire, and that is the reason it causes the issues and the problems. Now I would like to tell the question of Dr. Narasawani. This question is to Dr. Hema, madam. Is the virus present in breast secretions? How long will the titer be in the symptomatic patient? Can torch panel be useful? How long to follow up? Basically, is the virus, we have already been told that the virus, even if it is in breast milk, it can be easily been given to the baby. So
It is not
I
in
think
breast.
that we have
It is
already
not present
answered.
in the breast milk. I think
Yeah,
Parikshit was
yeah,
very,
yeah.
very clear
Breast
in
secretion.
his deliberation when he said that the breast milk, when you test it, they have not found the evidence of virus being present in the breast milk. And therefore, even if you choose
Yes.
to separate the mother and the baby, you can still express the breast milk and give it to the baby, is what he said. It is very human resource intensive to shift the baby outside of the mother and have a new caretaker take care of the baby, because God knows her status and her hygiene and how she will take care. So it's all going to get very much more complicated if we involve too many more people. So the skin to skin contact, mother and child bonding, whatever, all that will stay. Breast milk immunity will stay, and the mother can feed the baby with her hand hygiene and masking herself so that her droplet infection doesn't go to the baby,
Yes,
and
yes,
keep the
yes,
cradle
yes.
at 3 feet distance, so that is also, again, it's a distancing of the baby and herself to that extent. I think there we should
Yes,
stop
madam.
and
So
not,
I think Dr. Naraswani has joined later. Dr. Parikshit had already described the whole thing that the uh, virus is not secreted in the breast milk, and it has already been mentioned. But I think he has joined later. That's why we are repeating such questions again, because there are now readers and the audience which have gone to more than 2,350 questions. But we already taken 50 of them, and there are some 10-15 minutes left. So we will be asking Dr. Reshma Pai, madam. You wanted to say something. You had raised your hand.
Um, uh, really regarding,
And please remove your headphone. It will give you the clear audio.
can you hear me?
Yes.
Yeah.
It is it is cracking, madam, but if you can be a little louder.
Okay. The question I wanted to point the legal.
Not able to hear you.
You're cracking.
Madam, I think there is a issue. We will come back to you soon. There is one question of Dr. Parul Shah, and I give it to Dr. Bhaskar. Dr. Parul Shah has asked a question. Can hydroxychloroquine be given to pregnant women? If so, what is the dose?
I would pass on that question to Parikshit, because I am
Okay.
not convinced that everybody, even all healthcare workers, personally, I am not convinced that every healthcare worker should be given hydroxychloroquine. We are giving it to our doctors who are manning the COVID ward, and we told the others, if you have an exposure and without a PPE, or you have a PPE failure, we'll give you. But my advice to healthcare providers is, if you want to take hydroxychloroquine, and if you are taking any other medication, or you have an existing problem, existing healthcare issue, please talk to a physician before taking that dose. So if I'm not convinced about giving it to myself, I'm not convinced about giving it to the patient. So let Parikshit answer. I think he has a different take on that.
No.
Parikshit?
Bhaskar, I agree with you completely on that front. That simply as a prophylactic medication, HCQS is probably not the way to go. But meeting certain criteria, that means if it's a moderate to severe kind of a disease, then HCQS and azithromycin is probably our best bet as far as the treatment of the viral disease is concerned. At the moment, there are two approaches that we have. One is HCQS and azithromycin, and the second is antiviral drugs.
Yeah.
Now, HCQS and azithromycin has been tried. One huge data set coming in from France, Gottlet et al., and they've shown a much better response than placebo. The antivirals, ritonavir and lopinavir, have been tried, but the results are not so good. They are as good as placebo. Some health authorities in our country are recommending that we use oseltamivir, the swine flu drug. Now, I really don't know how this recommendation has come about. It could be just that there are plenty of swine flu tablets left over. I really don't know why they thought about giving this. Uh, we'll just have to wait until somebody shows that it's actually an effective drug.
Can I come in? The Paris study actually
Yes.
has very small numbers, and it did show that the antivirals decreased your ICU stay by half from 11 days to 5 days. So that is a very significant take. But everybody's trying shooting in the dark. I saw the AIMS protocol. It does have azithromycin and hydroxychloroquine. There are some which are steroids. But reading what is every day, new things are coming out. But what is coming out, I think more people are getting into agreement that you should avoid an early intubation. You should avoid putting the patient on ventilators soon. Keep on giving oxygen, and unless your back is to the wall, do not intubate the patient and put on the ventilator. I am very blessed because we've got a very solid intensive care and pulmonology team. So we do not have to get into the treatment of the COVID, but this is what we get to see in the literature, what is coming out from initial experience in the West.
Yeah.
I would like that are already taking hydroxychloroquine and 400 taking 400. Many of those who are actively working, actively seeing day-to-day basis are taking, and there are very negative. If you are yet, have a
Madam, your voice is cracking. I think you will have to use. Yeah.
Can you take the microphone? Can you take the microphone close to you?
There is a.
Yeah.
Is
fine,
Rishikesh
better.
there around? Yeah, he can give you. He can lend you his headphones.
Is it better now?
Yeah. Much
So,
better.
lots of doctors are already using prophylactic hydroxychloroquine. It's a safe drug. I have experience with it. It's been used for malaria. Patients with arthritis have used it for years on end continuously without many negatives. So it's a drug which is, there's a lot of experience in the Indian subcontinent with hydroxychloroquine. And personally, that lot of doctors who are seeing patients on a day-to-day basis today are already on prophylactic hydroxychloroquine. So unless I think there are changes, unless there's a prolonged QT, there are many other drugs which to using the relatively safe drug. And many, of course, because there is no real drug available as a prevention, and this is a comparatively safe, maybe for healthcare personnel.
Yeah, I will just add, Rishma, on the same note, in our hospital, those who are on COVID duty, they are being given hydroxychloroquine. Anybody who comes into exposure is advised hydroxychloroquine. The hospital provides that. On the other hand, anybody who's not doesn't fall in that category, if they want to take it privately, it's their business.
Can I just in one point, Bhaskar?
Yeah.
Yes, Dr. Shanta Kumar. Yes.
Those who have had an history of any patient like among the doctors in their hospital, then as a prophylactic, it has been administered. There was an case in our hospital 14 days back. So then, because that administrator was positive, almost all the consultants and everyone were put on prophylactic HCQ. So it's an individual basis, and I think at this junction we don't have recommendation of universal HCQ to all patients and all doctors. But definitely those working
coming into contact,
it is advocated.
Okay, madam, there is one question from Dr. Ritu Yadav. Non-high risk primary patients with term pregnancy in latent labor with COVID positive, should we do LSCS or wait for normal labor? Dr. Shanta, again, it has been repeated, but we have many audience and many people are asking the same questions, but for the benefit of our audience, we have to take them again.
What is the question?
In a non-high risk case, who is a primary gravida,
madam, and she's in latent labor with COVID positive, should we do a section or it should go for a normal delivery?
Right
Followed
now,
by-
as we have already discussed, there was a very small study from China, how much to believe that they have done cesarean section. But I think even our Foxy GCP is very clear that the indications for cesarean section has to be followed.
Yeah, having said that,
Okay.
Rishma has pointed out some logistic issues that you need to see that if it's a primary patient, if the patient goes through 16 hours of labor, that you have the facility and manpower to look after her with the PPEs. It is just like doing a trial of SCAR is very easy to do in UK where you have a one-to-one midwifery care. So those logistic issues have to be taken into account. Otherwise, yes, the official line is that just because she's COVID positive, she doesn't need a section. But you have
Alka
to
madam
judge
wants
it
to
with
say
the practicality of the situation.
She doesn't need a section for obstetrical indication, but
Yes.
Okay.
seeing the surrounding atmosphere, it is for COVID.
Logistic reason.
Rishma madam, you raised your hand. Then we move on to the next question. We have a question from Dr. Bipin Pandit. How do you ensure that the patient you are treating is not COVID-19 infected? How do you ensure?
That's why we said, Niranjan, that universal precautions need to be followed, because unless proved otherwise, everybody is actually a COVID suspect, because there is a large proportion of them who are asymptomatic. If you take that into consideration, then anybody can turn out to be COVID positive if and when they're tested.
I think,
thank you.
given, I think to add to that Bipin's question is that it depends on where you are staying. If you are staying in a place like Mumbai or Kolkata, at the present moment, you have to assume everybody is COVID positive. If you are in a city where there has been one case and you know that the proper testing is properly happening, like we were 3 weeks back, a proper history and a proper contact history would reasonably do well. And I think it depends on geography.
One more question from Dr. Chembuli. It has been repeated, but I can't help it. Can steroid be given to a pregnant woman for preterm labor when she is COVID positive?
Yes.
Dr. Alka, Dr. Rishma.
Yes, steroids for the obstetrical indication can be given and should be given, because the benefit is more versus the risk. But there are few studies, if you see the literature, that in a very serious case, they're giving the steroid. There was a study I came across that it further worsened the lung condition, but that is anecdotal. It is for a very severe case where she already has severe lung problem. For routine patients, dexamethasone will be better than not giving it, because benefit will be more.
We'll continue with the dexamethasone to be given in preterm patients, and if they have any respiratory issues, then we have to think about it.
If the patient is a serious disease, then you discuss with your intensivist that this is the dose. But we know from our about our chorioamnionitis and etc. that the dose of steroid that we give does not increase your risk of infection. In fact, there are some hospitals who are now saying that they would rather give steroids in severe patients also.
Dr. Emma, the nation wants to know, Foxians wants to know, is there any mathematical study done to understand how to approach the COVID? Do we look at the yo-yo approach like in cricket?
Why Niranjan? Why me and mathematics? See, I think the escalation is going to happen in terms of numbers that everybody is in agreement with, because the more numbers who are tested, proportionately, the more will turn out to be COVID positive, but not necessarily in the sick bracket. In the previous question on steroids, I would like to add that if the pregnant patient, many a time she's not even tested for her sugar levels. So diabetes is a very serious comorbidity with the COVID positive patient.
How can we have Emma for 40 minutes without uttering diabetes?
Yes, so there I get my opportunity, because there if you give steroids and if she's given steroids and her condition deteriorates because of COVID, because of diabetes, because of
diabetes.
steroids,
But now the diabetes has to come inside, and it is right. Foxians want to know, a patient with diabetes, with COVID positive, the treatment will be the same. Only the issues about COVID will have to be handled. and I think, madam, you have given justice to the question. We move
But
on
please,
to other.
Mathematical escalations will happen, but to minimize the contacts and to minimize the spread, to flatten the curve. And yesterday's Foxy meeting, Dr. Alpesh and team said, we will not only aim to flatten the curve, but we'll crush the curve. So that's the spirit with which the Team India and Team Foxy is moving
but
ahead. So
yeah, but
congratulations.
please remember, in pregnant patients also, the same risk factors for severe disease stand, which is hypertension, which is diabetes, which is asthma, which is chronic lung disease. If a pregnant patient with COVID positive, any of these, you please think that she's more likely to be among the 15% than the 85%.
Because there was some
Dr.
comment
Parikshit,
by an
you want-
expert, Niranjan, there was some
Yes,
comment
ma'am.
by an expert on the media saying that we don't have so many elderly in our country as in Italy, so we may have less number of fatalities. But I responded to that by saying that 40 to 60 years bracket, which are full of comorbidities of hypertension and diabetes, are really at a much younger age, they're at more serious risk. So we have to pay the same degree of attention in our country too.
Dr. Parikshit, would you like to add here regarding the mathematical model?
Well, these are all speculative models which have been developed. I think it's not fair to subject the population to these kind of speculative models, because it leads to nothing but either downplaying the condition or scaremongering. So I don't think it's yeah, exactly. And
Time will tell.
I think we seem to be on the right track at the moment. Let's
I
keep
think
going
India
that
is
way.
doing. India is going a little better. Let's hope the testing improves and we get this graph going down over a period of days. There are 3 questions which I have to ask. Dr. Shweta Narayan is asking minimum number of pregnancy scan during COVID-19 pandemic.
Just the 12 and the 19.
Yeah, the FIGO task force has gotten a recommendation of the minimal number of scans. According to them, the rest of the in-between visits can happen on the phone or the video call, but 12 weeks, 20 weeks, and close to term, especially if there is added high risk. So these 3 scans is what the FIGO task force has recommended as the minimal.
Okay, there is one more question now. It is, should we take HCQs to our family members, especially those healthcare workers who go back home and then they have high risk to expose to their babies, to their children, to their
parents,
wife or husband? So what do you recommend? It's a very important question.
I think nobody has an answer to this question. Everybody has an opinion on this.
Okay.
No clear-cut guideline, no clear-cut benefit, but I'm also taking HCQ.
But madam,
thank you.
Taking, but I have not given to my family member.
Is it? No, family means husband also, we two are there. So Shanta, both have to on their own ground take it.
Husband and parents are also.
And husband is very particular, weekly.
Okay, so there are many questions which are there. We will take.
Rishma wants to. Rishma, please unmute.
Yes,
Rishma.
Rishma, please go ahead. Last one answer by Dr. Reshma, then we conclude.
We can't hear you, Rishma. Please unmute.
Unmute.
I think this is important for all of us and the biggest fear not for ourselves, but for our, especially for parents. That so there has to be very, very of quarantine for people who are at the present moment. We have to literally quarantine, come home, follow the instructions of discarding most of your things outside of the door. Be open, not have wash completely, have a shower with the hair, and then yourself as much as possible. So I think these instructions are very, very important. Also, as possible, your hospital staff, if you can keep them in the hospital itself. The staff is sometimes staying in homes with they're exposed. So when these staff come to the hospital, again, there's a problem. So the important thing is to keep people in the hospital from your staff. Come home. Come home. Well, maybe it's better if you're seeing COVID patients. But safety is extremely important. Those strict instructions, that is really not easy.
Thank you. Thank you, all of you. And it was a pleasure to have all of you, the galaxies which are there present with us. TOG has culminated into digital print and conclave platform thanks to Dr. Reshma and later our president which have been there, and we have witnessed an intense and varied topic being introduced in our webinars. This time too, you all have created a magic in this topic, and we had more than 2,000 members, Foxians being joining us, and it was a surprise that Dr. Shanta Kumari from South, our president-elect, joined with us, and it was such a wonderful experience. She's our dynamic, power-packed Iron Lady of South India, and obviously you were all wonderful participants. Dr. Alka Kriplani, Dr. Bhaskar Pal, Dr. Parikshit Tang, Dr. Hema Madam, and obviously Komal, who conducted the Master of Ceremony job. This is the most important thing. I would like to thank our President, Dr. Alpesh Gandhi, who made this happen. He has given us the permission to go ahead with this TOG webinars along with Foxy Medical Disorder. And I would like to thank our Secretary General, Dr. Jaideep Tank, and Dr. Atul Ganatra, the Vice President in charge, who have taken initiative in this.